You can begin.
Good morning and welcome to the second meeting of the House Cannabis Legalization Workgroup. It's the 13th of October, 2021. This is a virtual work group meeting, so please be patient if we encounter any technological or streaming issues this morning. Before we begin, I remind workgroup members that we're being live streamed on the Maryland General Assembly's YouTube channel. Workgroup members are going to be muted through the briefing. If you have a question after our presentations, and we're going to hear from 3 people presenting this morning, please use the raise your hand function within the Zoom window. After I recognize you, Dylan will unmute you and you'll be able to ask your question. We're going to receive a briefing today regarding the related health impacts and factors associated with cannabis use and its legalization across the country. According to the Center for Disease Control, 48.2 million people used cannabis in the United States in 2019, which means it is the most commonly used federally illegal drug in the country. To help us better understand the health and safety impacts of cannabis use on topics ranging from addiction to brain development and mental health, we have invited 3 panelists to be with us today, and they're going to share their expertise with us. I'd like to thank Delegate Jocelyn Pena-Melnick, who is the chair of the work group's Health Determinant Subcommittee, for working with us to organize and invite these guests. First, we'll hear from Dr. Patricia Fry, who is the medical director at Tacoma Park Integrative Care and serves as an associate professor for medical cannabis science and therapeutics at the University of Maryland School of Pharmacy. Next, we'll hear from Dr. Susan Weiss, the director of the Division of Extramural Research at the National Institute of Drug Abuse. Dr. Weiss will deliver a presentation on the health effects of cannabis legalization. And finally, we'll hear from Taylor Koski. Ms. Koski is the Director of Policy and Government Affairs at the Maryland Medical Cannabis Commission, and she will discuss the health and safety impacts of cannabis legislation. We'll open it up to questions and answers after we hear from all 3 panelists, and I request that work group members be patient and keep note of the questions you'd like to ask as you listen to the presentation. And we have a significant comprehensive briefing ahead of us, so I'd like to get underway and introduce our first guest, Dr. Fry. Dr. Fry, if you're ready, you can go ahead.
All right, thank you. Thank you for inviting me. I did have a slide presentation. I think Dylan was going to share those slides with you. It was a great pleasure to talk to you about what I consider to be one of the most beneficial, yet one of the most misunderstood and malaligned potentials on the planet. Next slide, please. Next slide. As you probably already know, cannabis is not a new medicine. It's been used medicinally, and we're still on the same slide, on the back slide, please. Well, I'll just continue.
I'm sorry, Miss Dr. Fry. We are on the 3rd slide on our end.
Well, I'm on the 2nd slide here.
Let's go back a slide.
There we
There
go.
we go. The history of cannabis medicine?
Yes. Well, I'll
All right,
just go
great.
through it. You don't have, what I wanted you to see on the slide actually were the 2 prescriptions, one written in Kansas, I think in 1937, 1915, and the other prescription written in North Carolina in 1937. So this, it's been used as medicinally and spiritually for millennia. The first recorded reference documenting the use of cannabis is as far back as 2700 BC in the Chinese Pharmacopoeia. There are Egyptian papyri documenting its use for treating menstrual cramps in 1400 BC. It was one of the first general anesthesias when combined with moonflower and wine by the Chinese surgeon Huotou in about 150 AD. And then the Persian philosopher Avicenna, who authored the Canon of Medicine, which was the go-to medical referenced throughout Europe up until about the 11th century, referenced its use in the treatment of pain and other conditions. And it was introduced to Western medicine in 1848 by the Irish physician William O'Shaughnessy, who studied its use and efficacy while he was serving the with the British East India Company in Calcutta, and it entered into the European Pharmacopoeia and then the US Pharmacopoeia in 1857. And there are a number of case studies documenting its efficacy in treating conditions like seizures, pain, depression, insomnia, and even croup. And as you and as I referenced earlier, I really enjoy showing these old prescriptions where doctors were able to use cannabis, usually mixing them with other botanical extracts to treat a number of conditions. Next slide, please. So in I think it was 32, when the head of the Federal Bureau of Narcotics painted a picture of this menacing drug that turned people into sex fiends and axe murderers called marijuana, it was the Legislative Council of the American Medical Association that argued that not only had he never heard of these types of problems, but that the medical community was not even aware that making cannabis illegal was up for discussion because the name of the plant was cannabis and no one had ever heard of the word marijuana. Next slide, please. So later in the 20th century, scientists really wanted to know what this compound THC was interacting with to cause this euphoric high that was associated with cannabis use. And then the endocannabinoid system was discovered. And it's a very old system. It's probably older than 300,000 years. And it consists of receptors and ligands, which are molecules that either activate or deactivate certain receptors, and neutralizing enzymes that hydrolyze or break down these ligands once they're no longer needed. And it's a system that appears that its sole purpose is to create homeostasis or balance within the body. And it's present in every living thing from jellyfish to humans, with the exception of insects, which appear to have their own signaling system. And the endocannabinoid system allows us to sleep, eat, forget, and relax. And it modulates the immune system as well as almost every other neurotransmitter system in the body. Next slide. So this is a rather complicated illustration to illustrate that this is a complicated system, and that there are many receptors in the endocannabinoid system, and it interacts with two receptors that have been identified called the CB1 and CB2 receptors, and these are integral to the system. The CB1 receptor is found mainly in the central nervous system, and the CB2 receptor is mostly found in the immune system and in peripheral organs. And the system also interacts with a number of other receptors that are involved with inflammation and pain. And two of the ligands are these chemicals that activate the receptors in the endocannabinoid system are anandamide and 2-AG, which is arachidonyl glycerol. And unlike other neurotransmitters that are made and stored in vesicles, these neurotransmitters are produced on demand. And once they do their job, they're hydrolyzed by enzymes. One is fatty acid amide hydrolase, which we call FA, that breaks down anandamide, and monoglycerol lipase, which is called MAGL, and it breaks down the neurotransmitter 2-AG. And then within the system, we have the cannabinoids from the plant, and there are probably over 120 different cannabinoids, but this system is what we refer to as the endocannabinoid system. These phytocannabinoids come from the plant. Next slide, please. And so the cannabinoids with which we're most familiar are CBG, which is one of the, she's the stem cell, the mother cannabinoid, from which all other cannabinoids are made either by enzymatic action or by metabolism. And there are some acidic precursors to CBD and THC, which are CBDA and THCA, which come from the unheated plant. They have a lot of medical benefits. THCA is not impairing. There's THCV and CBDV, and of course CBD and THC. Now, all of these cannabinoids were patented by the Department of Health and Human Services as neuroprotectants and antioxidants, and I believe it was about 2003. Next slide, please. So due to the action of these cannabinoids, cannabis in many patients, but not all patients, can alleviate pain, promote restorative sleep. It acts as a muscle relaxant. It reduces anxiety and stress. It can stimulate or suppress appetite, depending on which cannabinoids are being used. There are other psychiatric effects, which include mood stabilization. Both CBD and THC are antipsychotic. Well, THC at low doses is antipsychotic. And it is a they're well-known anti-inflammatories. They have neuroprotection, they have antioxidant activity, and they modulate a number of metabolic functions. Many of these things have been shown in preclinical or animal studies, usually in mice, and not everything that transpires in rodents will apply to humans, but we do see anecdotally and observationally a lot of these effects in many of our patients. Next slide, please. Next slide. So the National Academies of Science, Engineering, and Medicine are private nonprofit institutions that provide expert advice on some of the more challenging topics in science. And they have a really solid reputation in the US as the premier source of independent expert advice on scientific, engineering, and medical issues. And in 2017, the Committee on the Health Effects of Marijuana reported on cannabinoids, and the committee consisted of very prominent university researchers. The report was then reviewed by individuals chosen for their diverse perspective and technical expertise. And the purpose of this independent review was to provide critical comment that would assist the institution in making a published report as sound as possible, and to ensure that the report met institutional standards for objectivity and evidence. And it came as no surprise to me that they found conclusive evidence that cannabis is effective in the treatment of chronic pain in adults. And this is not to say that cannabis is ineffective in treating children, but there are just no studies looking at the efficacy of pain treatment in children. Children also respond to cannabis for pain issues, for conditions like Ehlers-Danlos syndrome, mitochondrial disorders. They have migraines. We have sickle cell. We have a lot of treatment-resistant pain issues in the pediatric population. Also, it wasn't surprising to find that they found moderate evidence that cannabis is effective in improving short-term sleep outcomes, and limited evidence that cannabinoids are effective in alleviating PTSD and anxiety. And the anxiety, they use performance anxiety because those were the studies, and it doesn't mean that cannabis is just effective in treating performance anxiety. It is, we find clinically that it's quite effective in treating generalized anxiety disorder and a number of other anxiety syndromes. Next slide, please. So who are the patients? In my practice, about 47% of all my patients are over the age of 60, and 26%, and another 26% are between the ages of 40 and 59. So 73% of the patients I see are over the age of 40. And only about 9% are under the age of 18. And I am a board certified pediatrician, so I do see a lot of the pediatric referrals from Children's Hospital, from Hopkins, from Maryland, and from private, from pediatricians in private practice. And only about 2% that I see, at least, are between the ages of 18 and 24, which historically that was the age group we were really concerned about overuse or misuse or use disorder, but they don't come to me. And patients over 40, I just might add, which is most of my practice, is not terribly interested in smoking cannabis, nor in being impaired. These are patients with long-term problems that have been, for the most part, treatment resistant. And while I say that, I don't feel cannabis should be preserved as a third or fourth line medication. I think for many instances, many conditions, it should be a go-to for first line. Next slide, please. And so in my electronic medical record, I'm limited to collecting data only on individuals who identify as male or female. So I don't have any data on non-binary or genderqueer, but for now it's male and female patients are about equal, actually with a slight increase in males in the population under 18, which may reflect the increased prevalence of autistic spectrum disorder in males, and I do treat those patients. Once you get over 55, females tend to outnumber males, and this also may be a reflection of autoimmune disease, which I see a lot of, and it is definitely more prevalent in women than in men. And these conditions with autoimmune illnesses are highly associated with chronic treatment-resistant pain, anxiety, and a number of other medical problems that don't get better with medication. Next slide, please. In this slide, we can see that pain has been the #1 reason why patients sought out medical cannabis, followed by anxiety. However, in 2021, interestingly enough, pain fell behind anxiety as being the most common clinical complaint that I saw, which may be related to COVID. I also saw a huge jump in anxiety right after the 2016 election. No joke, the phone was jumping off the hook, but that seems to have settled. Next slide, please. So the conditions that commonly respond to cannabis medicine are inflammatory and neuropathic pain that are usually part of a constellation of symptoms associated with autoimmune disease, as I just said. Mood disorders, insomnia, which includes insomnia caused by sleep apnea, treatment-resistant chronic pain syndromes and migraines, muscle spasm, whether it's from cerebral palsy or neurodegenerative diseases, or even, people don't come to me for Charlie horses, but cannabis is very effective in treating those topically. Sexual dysfunction due to anxiety, stress, and or pelvic pain or pelvic floor dysfunction, and gastrointestinal conditions such as irritable bowel syndrome and inflammatory bowel diseases like Crohn's and ulcerative colitis. I see quite a number of pediatric patients that are referred from the pediatric gastroenterologist. A lot of these kids don't respond to the biologicals and do very well with cannabis, particularly CBD. Also, CBD modulates GI motility. There's some studies that show that it decreases diarrhea, which is true, but it also helps patients with chronic constipation. So it seems to modulate that GI peristalsis depending on what is needed. So we see improvement in both constipation and diarrhea. Next slide, please. So what adverse effects do we encounter? THC at any dose can cause dry mouth. Inexperienced patients may experience increased heart rate or a decrease in blood pressure, particularly with inhalation, which can be a concern for patients with unstable or significant cardiovascular disease. We don't want to do anything to the heart that's going to increase oxygen demand and perhaps precipitate an infarction. I have not seen that, but theoretically that could happen if if the disease was progressed to the point that just a little change in heart rate or blood pressure could cause problems. Other effects include impaired reaction time and poor coordination, which would be expected to adversely affect driving skills. But the adverse effects that are associated with THC can be mitigated with the use of CBD in combination with THC. The red bullets, amotivational syndrome, cannabis hyperemesis syndrome, and cannabis use disorder are really associated with prolonged use of high doses of THC, and these doses are much greater than are typically used for most medical conditions. And the euphoric high is euphoric for many patients or people, but a lot of people experience dysphoria from THC. And CBD is a really pretty safe cannabinoid, as they all are really, but it has the potential to cause some drug-to-drug interactions at higher doses. We may see these at doses greater than 30 or 40 milligrams, and these have been described particularly with some anticonvulsants like valproic acid and clobazam, which is a benzodiazepine. So using CBD with some of these anticonvulsants, we have to be careful about spacing them apart from the anticonvulsants or adjusting the anticonvulsant doses. So it's certainly something that can be accommodated. We can see appetite suppression, which can be problematic for patients with anorexia nervosa or wasting syndromes with cancer or AIDS. And CBD does decrease gastroesophageal sphincter tone, which may exacerbate GERD symptoms. And it has been found to increase intraocular pressure. So those are sort of the more common adverse effects. And of course, individuals respond to each medication and pharmaceutical differently. And I'm sure there are others, but this is what we're most commonly concerned about. Next slide, please. And so I don't want to be misunderstood about the euphoria because while the benefits of cannabis have been limited by its intoxicating effect or the intoxicating effect of THC, the impairment is not always an adverse effect as reported in most studies. You know, Mother Nature probably knows that there are many people who suffer from mental and or physical pain that just need a break. And perhaps during that time when THC activates the very same receptors that are activated by meditation, deep breathing techniques, therapeutic massage, and enjoyable exercise, these patients can benefit from a few hours of mental and physical respite. So I don't consider the euphoric high to always be an adverse effect. And as I said, it's not euphoric for everyone. Next slide, please. So how do we dose? Every person's endocannabinoid system is quite unique, so there really is no dosing. There's a lot of difference in the numbers and sensitivities of these cannabinoid receptors, so there's no one size fits all, as is typical with most pharmaceuticals. So however, studies have indicated that while there are exceptions, THC doses under 20 milligrams or so, above 20 milligrams or so is relatively ineffective at alleviating pain. And these phytocannabinoids have what's called a biphasic effect, which means that if you increase the dose, you increase the efficacy, but only to a point. And the graph on the, or the little bell-shaped curve on the right illustrates that. So after increasing the dose, actually, if you increase the dose too much, it actually decreases the efficacy, such that if you give too much, giving too much is the same as not giving enough. And if you give way too much, it can actually cause or exacerbate the symptom that you're trying to treat. Hence the anxiety and paranoia that occurs with high TH doses. When at low doses, THC can be quite anxiolytic. When people take too much THC, the receptors react by shutting down so that it takes higher and higher doses to experience the same effect. And this is what tolerance is, and it often accounts for the high THC concentrations sought after by adult users. And I mean adult users in that they are using cannabis more for a recreational purpose. And some of those patients are self-medicating and have underlying mental health issues. but keep and continuing to increase the THC dose generally just means that you're just going to need more and more. So medical users can experience this as well if they are using predominantly THC medicines or THC only products. And the way to avoid this is to combine some CBD with the THC and to take medication breaks when patients feel that the dose that they've been using is no longer effective. And I warn patients to resist the urge to increase their dose, but to instead take just a 3 or 4 day break from THC. Then they can go back and starting at a dose that's about a third of the dose that they were using before, they can titrate up. And this usually results in an effective dose that was even lower, that's even lower than the dose they were taking before. And it's important to remember that the peak of the curve is not always zero symptoms. The peak of that curve may be that symptoms are half as bad or 3/4 as severe, but that may be the best that medicine is going to do. So we don't always get complete alleviation of symptoms. Next slide. There are a number of ways that cannabis can be administered. I usually recommend using oral mucosal approaches when possible, which means that the medicine lingers in the mouth, usually under the tongue for a minute or so, and is then swallowed. Some of the cannabinoids are absorbed directly into the bloodstream via those capillaries in the mouth, which shortens the onset of action, and the rest is swallowed and absorbed via the GI tract, which helps it last longer. So while the onset of action is a little bit longer than intranasal or inhalation, the duration of action can be substantially longer, which is desirable for actually getting up under the problem and preventing symptoms from recurring rather than chasing symptoms, which is typical with inhalation because it just doesn't last long enough. Intranasal and inhalation can be very helpful for aborting seizures and migraines, or when rapid relief is needed, say for severe pain, or someone's back seizes up. But for patients, inhalation, which reaches similar plasma levels as taking cannabis intravenously, is the only way. Some patients, it's the only way that they can achieve therapeutic levels if they happen to be rapid metabolizers, meaning that they metabolize the molecule before it actually reaches a high enough level to interact with those receptors. And this is particularly true when tolerance has occurred after prolonged use of THC, that inhalation is about the only way they're going to get levels high enough to get the effect that they're looking for. Topicals activate receptors in the upper layers of the skin and can be very effective in alleviating joint pain and rashes. Transdermals usually push are supposed to push the cannabinoids into the bloodstream, and they can be used when sustained release would be beneficial or if it's difficult to administer other forms of medication. And edibles are helpful for treatment-resistant pain because when delta-9 THC is consumed, it's converted in the liver to an 11-hydroxy-THC, which has increased pain-relieving effects, but it's also more intoxicating. And the problem with edibles is that the absorption is very unpredictable, and it varies according to what food is in the stomach. These are fat-loving molecules. If there's a watery environment, you're not going to absorb much. If there's fat in the intestines, you're going to absorb more. And hence, when when people start taking more and more edibles because they don't think they've taken enough because it hasn't started working, and then when it all kicks in, they end up on the floor miserable, thinking they're going to die, but they won't. But they have to suffer through that until the body metabolizes it. So I don't recommend edibles except for at bedtime for either bedtime for nighttime pain relief or for insomnia. Next slide, please. So cannabinoid ratios are important. And when medical and adult use are mixed, the industry tends to focus on the high THC. They tend to they charge more for it. There's higher demand for it. But now it's gotten to the point where it's difficult to find CBD products and almost impossible to find flower with CBD in Maryland. There are 3 or 4 products and with our tinctures, there's some tablets and some chews and gummies. But when the program started, we had a number of different flower varietals that had one-to-one ratios of CBD to THC that worked well for patients. But they don't grow them anymore, and they don't sell, I guess because they don't sell the way the high THC varietals do. And the few tinctures that are available tend to contain emulsifiers and colorings and flavorings, which all can be problematic for a lot of these very sensitive patient populations. So next slide, please. So what are some of the social concerns? Next slide. So I didn't know Dr. Weiss was going to be here. I'm sure she'll talk about this. So I'll just briefly say that if we look at the risk of addiction or use disorder from cannabis, this is an old study done by Henningfield and Benowitz in 1994, looking at how certain drugs rate in terms of withdrawal, reinforcement, developing tolerance, dependence, and intoxicating effect. And we see that the cannabis really is pretty low on the totem pole there. And we might think that, well, maybe these reflect characteristics of cannabis flower that was available in 1994 that may have had lower THC content. But there have been some other more recent analysis, Solarian, for example, that continues to support that cannabis is has a less addictive potential than alcohol, heroin, cocaine, opioids, psychostimulants, and nicotine. Next slide, please. So with legalization, we have concern about these children or adolescents, and would legalizing cannabis open the door to exposure or misuse in young people? And in 2017, with 29 states having legalized medical cannabis and 8 states with adult use, the CDC found that prior month cannabis use by high school age youth was 19.8%, which was less than half of the rate in 1997, paralleling the decline that they observed in alcohol consumption. So my theory is that teenagers may not be all that interested in using the same stuff grandma uses. Next slide, please. And according to this National Survey on Drug Use and Health that looked at cannabis use between 2008 and 2016 with a rather large cohort of over 500,000 people, they found that problematic use in the 12 to 17-year-olds increased from 2.18 to 2.72%, comparing the period before legalization versus after legalization. And they found no change in the 18 to 25-year-olds, which is interesting because that's the demographic that we've always been most concerned about developing cannabis use disorder, or at least in males. And that in the 26 and older group, cannabis use increased from 5.65% to 7.1%, and frequent use was defined as using cannabis at least 20 times per month. And that increased from 2.13% to 2.62%, and past year cannabis use disorder increased from 0.9% to 1.23%. Next slide, please. And so the good news is that according to drugabuse.gov, that while cannabis use amongst high school seniors has not changed much at all, it's actually slightly lower than it was in 1997. Tobacco smoking has plummeted from 36.5% to 7.6%. And there was no reference to vaping nicotine. But I believe that these statistics suggest at least that cannabis legalization has not severely or adversely impacted teen underage use, at least not according to these statistics. Next slide, please. And when it comes to motor vehicle accidents, It stands the data, as it stands, the data on cannabis is a little murky for a number of reasons. One, driving under the influence of cannabis is defined as measured reduction in cognitive and psychomotor skills and a defined THC concentration in blood, oral fluid, or urine. However, there are no real defined levels that can be consistently representative of impairment. So cannabis impaired driving is not the same thing as being cannabis positive. And time of administration, experience, cannabis experience, tolerance, and dose impact the degree of impairment. And heavy chronic users can have relatively high levels and experience little, if any, impairment, whereas a new user may have relatively low levels and be significantly impaired as to impact driving. And low THC concentrations can be detected for several days in chronic smokers. So when they looked at lane weaving as a measure of impairment, they found that after vaping a type 1 or a THC dominant and a type 2, which is a THC CBD ratio of 1:1, that lane weaving was shown to be greater than when subjects were than the subjects who received placebo at 40 minutes and at just over an hour and a half. But there was no difference compared to placebo 4 to 5 hours later, when THC is likely to still be measurable in the blood and metabolites will certainly be present in the urine. And there's no significant difference between type 3, which is CBD dominant, versus placebo in lane weaving. However, even patients using CBD dominant products may test positive for THC because there's usually some THC in those products. Another example is that THC levels above 2 micrograms per liter can be present in occasional smokers for 26 hours, long after any impairment would have no longer be an issue. And frequent smokers can have even higher levels for more than 72 hours after using cannabis. There's an article, a paper at Prusi et al., who found that cannabis users were about 25% more likely to be involved in motor vehicle accidents than drivers with no experience with cannabis. However, they felt that other factors such as age and gender, particularly younger males, and not necessarily cannabis use, may account for the increased crash risk among cannabis users. So in summary, cannabis is a very old medicine. I'm sorry, next slide. It's a very old medicine. It has the capacity to achieve a wide range of symptoms due to the ubiquitous nature of the endocannabinoid system. It has an extremely high safety profile. It is not possible to overdose with cannabis to the point of dying. And when compared to many pharmaceuticals and over-the-counter drugs, it has very few adverse effects. It can, when used with the proper ratios and delivery methods, many of the adverse effects associated with THC can be eliminated. Cannabis is important for medical use. I feel very strongly that the products that are appropriate for medical patients cannot be overrun by what adult users are seeking. And the products are not the same, and we have to maintain a market so that our patients have access to appropriate ratios, methods of delivery, and that products should be affordable and non-taxed. And next slide. And if you'd like to take a deeper dive into cannabis as medicine, I will shamelessly plug my book, The Medical Marijuana Guide, Cannabis in Your Health. Next slide. And I thank you for your attention.
We'll now move quickly to Dr. Weiss, to Dr. Susan Weiss, who's the Director of the Division of Extramural Research for the National Institute on Drug Abuse. Dr. Weiss?
Thanks for having me. I'm going to be talking about this from a different perspective, but I want to say I've been on other panels with Dr. Fry, and I'm always very impressed because I think that her description and the way in which she talks about the medical use are really the ideal. And I think, there's a lot of knowledge, and obviously she's very clear about all of this. But what I worry about, and I think you would agree, Dr. Fry, is that in many states, the medical dispensaries are not what you're describing. And in fact, the products that they're offering are not any different from the recreational products. So I think, I agree with your conclusions that it's really important to keep the medical side of this different, and to be paying attention to the products that people are using and how they're using it. And I don't know the full range of things in Maryland, but I do think that I agree with, I think that it's important that there are people like you that are paying attention to these things, and I hope that that becomes more the norm than I think it is at this point. So I'm going to be talking about the health effects of cannabis legalization, and I'm really focusing more on the adult use side of things, and the use of products that are mostly THC. So next slide, please. So we've been watching over the past years and looking at, this is the National Survey on Drug Use and Health, which Dr. Fry also mentioned. It's a national survey, and it, like many other surveys, has been showing that can you see my arrow, by the way? Okay, then I won't use it. Okay, so that the use among 12 to 17-year-olds has been pretty stable, and a number of surveys are saying this. Among 18 to 25-year-olds, the use has been going up. 18 to 25-year-olds are always the users who use most. And among the 26 and older, use has also been going up. And one of the limitations of this survey is that this is the way they divide up the age ranges. So it's 26 and older. And I think one of the things that we're very concerned about are older adults who are falling into the 55 and older range, and they're not really very well characterized in any of the national surveys. And we do know that their use is going up. Next slide, please. So the other aspect is that among users who are using, they use more often than they used to. And this is basically showing you that between 2002 and 2019, the number of past month users has been going up. But among those who have used in the past month, over 40% report using 20 or more days, which is considered daily or near daily frequent use, and as opposed to about 30% back in 2002. And even this is really not sufficient granularity, because there's a difference between somebody who is using daily once before they go to sleep and somebody who is using all day long. And that is, again, one of the things that's not being captured in the surveys that we currently have. Next slide, please. So in addition to, even though the 12 to 17-year-olds are not showing increases in use, there is a decreased perception by all around the harmfulness of smoking marijuana regularly. This is another survey that NIDA supports, which is Monitoring the Future. It's a survey of 8th, 10th, and 12th graders, and it just shows that over time, the perceived harmfulness of using marijuana regularly has been declining. And this is true not just among youth, but it's really true among the overall population, including women who are pregnant. Next slide, please. And we do know that the landscape has been changing quite dramatically, that the potency of the flower products have been going up, and now there are a lot of other products that contain very, very high levels of THC. On the left portion of the slide is a potency product monitoring project that's been supported for a number of years, showing the difference between 1995 and 2017. But these products are from DEA seizures, so they represent the illegal market and not the legal market. And we know that that many of the dispensary products are in the range of 20 to 30% in terms of the plants. And I would point out that not just the THC potency is rising, but the CBD levels are very low, and the ratio of these is getting greater and greater. And as Dr. Fry pointed out, there may be important reasons to have CBD as a component of any cannabis product to offset some of the potential harmful effects of THC. There are also edibles, and there are also these very highly concentrated products which are used through dabbing and other mechanisms. Next slide, please. This is a slide that I took from Jonathan Calkins, and he's trying to make a comparison between cannabis users 20 years ago versus those that are using today. And what he's taking into account is not just the increased potency of the products, but also the frequency of use. And that 20 years ago, that people may have been occasional users. The average user may have smoked a few times over the weekends. And now people are using all day, every day, and they're using these very high potency products, and they're becoming tolerant to them. So they're really getting exposed to very high doses of THC. Next slide, please. And why do we care about this? We care because the adverse effects are worse when users are using high dose or high potency cannabis products. This is just one example. This is related to psychosis. This is a study that was done in Europe, and actually there were a number of other sites. But what it shows is that there are dose-related increases in the incidence. So this is first episode psychosis in these different countries based on the frequency of cannabis use and the potency. And in this study, they considered high potency cannabis 10%, which, as we know now from most of the US dispensaries, this is actually quite low. There is a very strong link between cannabis and psychosis, but that is not to say that cannabis causes psychosis, or we would see much more of it, but it's probably a causal factor in psychosis, along with other factors, along with potentially genetic vulnerability, as well as others. And it also, we know, causes earlier onset of psychosis in those people who are prone to it and can worsen the course. So again, I'm trying to also bring out the point here, though, that these higher potency products are more dangerous than those products that we had a number of years ago. Next slide, please. So what we are worried about is really those people who we think are at greatest risk. And some we have good data for, and some we have suspicions, and we don't really know completely. But these include, mothers and newborns, children and adolescents. Both of these are times in development when the brain is rapidly changing, and the endocannabinoid system, which Dr. Fry already described to you, is very important in brain development. And so using a substance that's going to alter the function of that system could lead to permanent changes. Although again, we don't know that these changes are permanent. Persons with mental illness, we know that, again, people, in addition to psychosis, there are other types of mental illness that could be worsened by exposure to THC products. Tobacco smokers, this is a question we don't really know yet, but it may, smoked cannabis products may also make it more difficult for tobacco smokers to cease using. And older adults are a big question, particularly older adults, where we have concerns around balance and risk for falls, cognitive impairment, as well as interaction with other medications or other degenerative diseases. Next slide. So I don't have time to go through all of this, but I did want to focus on the prenatal and the and adolescent use. So this is a study that was done in California by Kaiser Permanente. It's a very large healthcare organization, and this included almost 300,000 women, looking at the prevalence of marijuana use over time. And what you can see on the left is that prevalence is going up, but the bottom line, the yellow line, is self-reported cannabis use, and the black line is cannabis use as measured by either self-report or toxicology. And you can see that the numbers are actually, the percentages are quite different, which I think speaks to the fact that there's a lot of stigma for a pregnant woman to report any sort of drug use, including cannabis use. But it tells us that when we're doing these studies, it's important to get biological confirmation of these self-reports, especially among pregnant women. And on the right side, what you can see, and again, this is probably not that surprising, but this is a breakdown by age, and you can see that the youngest users, those women who are pregnant and under age 18, are also the ones that are most likely to use cannabis during pregnancy. And they use at a rate of between 20 and 25%. The same was true of 18 to 24-year-olds, and then women who are in these older age ranges, in fact, use very little. Next slide, please. So this is a bit of good news. This is also from the SAMHSA NISTA survey, that it does appear that overall, this is a national survey, it does appear that overall the use by the regular use, this is daily or almost daily use of women by pregnancy status, has decreased in the last 2 years after following a number of years where it had been going up. On the right side, you can see those women who are not pregnant. These are 15 to 44-year-old age range, and the percentage of daily use has been going up. And in the past, cannabis use has mainly been, there's always been very big differences between males and females. And I think at this point, females are starting to kind of catch up with males, maybe because of the differences now in the whole social norms about using cannabis. Next slide, please. So there have been a couple of studies that have tried to look at the overall effects of prenatal exposure to cannabis, and they tried to cover a wide range of ages. These are very difficult studies to do. There's always a lot of caveats. There's always a lot of confounds that are hard to get rid of. There were 2 studies that were done in the 70s and 80s, and 1 study that was started in the year 2000, and that the latter study is from Europe. It's Generation R study from which was done in Holland. And that one is an interesting study because mothers were using products that are more similar to the products that are available today, although they also almost always use tobacco in concert with cannabis, and there could be effects of the tobacco itself. But and the other studies that were done in the 80s, the products were very different, the patterns of use were very different. And again, there were many different sorts of confounds in terms of other drug use. So the effects are still somewhat consistent despite all of the different caveats. And one of the very consistent effects is that women who are using cannabis during pregnancy have lower birth weight, have babies with lower birth weight, that tend to have more hyperarousal. There have been reports of attention problems, of lower scores in verbal and memory domains, and externalizing behaviors, a greater risk of externalizing behaviors when these children are about 8 and 10. And as young adults, they have problems with executive function and early onset substance use. Now, again, I would point out that the farther you go from prenatal exposure, the less likely you are able to attribute it to prenatal exposure. There could be postnatal exposure. There could be many other factors that go into to these findings besides exposure to cannabis. But nevertheless, these 3 studies have kind of come to fairly similar conclusions. Next slide, please. And overall, there seems to be sort of a mild or a subtle to modest impact on cognition and neuropsychiatric outcomes that seems to be persistent. And again, whether it's just the prenatal exposure or some of the many things that happen subsequent to that is difficult to say. But we know that this endocannabinoid system is really important in many aspects of prenatal development. It's important for implantation, placentation, fetal organ development, neural development. And all of these things can then therefore be affected by the use of cannabis products or other types of exogenous cannabinoids, not those that are made within the body. We know that they cross the placenta, they accumulate in fetal tissues, especially brain. They're also found in breast milk. And there are some studies from aborted human fetal tissue that find alterations in dopamine receptors. These are important. These receptors are part of the reward system, motivation. They may be sex-dependent effects. And there are also preclinical studies that show lasting effects of THC exposure on adult drug seeking. So the preclinical studies tend to find similar effects to what the human studies are. They have the advantage that you can actually control the exact exposure. You can limit it to just THC, but the disadvantage that that the exposure is not the same as the way that humans are taking these products. And THC is not the same as the whole plant, which has other cannabinoids and other compounds in it. Next slide, please. So I wanted to switch over to adolescents because, again, this is the other group, one of the other groups that we're very concerned about. It's always really hard to show causality in long-term effects. I pointed out some of the concerns when you're looking at prenatal exposure, and many of the studies that have been done in adolescents are studying them after they have been using for a long term or whether they're in treatment. And so some of the changes that we find in brain function, for example, may be related to differences that existed before they started using substances. So studies like this are very important because they are looking at dose-related effects, and they sort of get us one step closer to understanding causality. And what this is a study that combines information from 3 different studies that were done in New Zealand and Australia, looking at the frequency of cannabis use before age 17 and adverse outcomes at age 30. And what they found is that those people who used cannabis more frequently had much higher likelihood of having some of these adverse outcomes. And that includes cannabis dependence, which is not that surprising, other illicit substance use. And again, I don't want to get into gateway issues because I think that's a different question, but I do think there is an association of those people who are using cannabis do use other substances. Suicide attempts, I really want to highlight this because I think this is such an important outcome, and it's something that is really emerging now in a number of different studies, regardless of whether or not people are also depressed at the same time. Looking on the right side of this, you can see that those who use more frequently are less likely to complete high school, to complete college. This has come out of a number of different studies. The link to depression is a bit more murky. Most of the studies seem to show that there may be a slight increase in risk of depression among adolescent cannabis users who are using frequently, but it's not a strong effect at this point. Welfare dependence is another area where it tends to go with that. So I think we have a lot of research that's sort of pushing in this direction of frequent cannabis use during adolescence has a risk for long-term detrimental outcomes. Next slide, please. This is also just to talk about the likelihood of developing a cannabis use disorder over time in those who start using when they're 12 to 17. And the point here is that, well, by 3 years, those who started using, if they're continuing to use, about 20% will develop a cannabis use disorder. But also that, despite the fact that overall cannabis does not seem to be as addictive as certain other substances, among youth, it may be actually more of an addictive substance. And that's true compared to cigarettes and alcohol in this study. Next slide, please. And this is not about youth particularly, but it's really to just remind people that people who have cannabis use disorders also tend to have other comorbid psychiatric conditions. I don't know which comes first, and this is not just cannabis use disorders. People with almost any substance use disorder are more likely to have other psychiatric conditions. This is really just to point out that if treatment providers are working with somebody with a cannabis use disorder, they need to be on the lookout for some of these other psychiatric disorders and vice versa. Next slide, please. And this is again a slide just to point out the fact that again among youth who start using cannabis and who start using it regularly, there are a number of studies that show differences in brain development. This is the time when the brains are developing. The study on the left was looking at connections between certain areas of the brain and found a large decrement in connections among early cannabis users in very specific areas, one of which is the hippocampus, which is important for memory formation. And the slide on the right shows decreased connectivity between the prefrontal cortex and nucleus accumbens in adolescent users with escalating patterns of use. And this is important because the prefrontal cortex is sort of the brake on the system, and the nucleus accumbens is involved in reward. So having a sort of weaker connection there could also affect why they both continue to use cannabis and could also have impacts on other aspects of their lives. Next slide, please. So cannabis use in adolescents comes with risks for adverse outcomes. Again, the endocannabinoid system is involved in myelination, which is a lot of what's going on in the teen brain that is developing. Also cell pruning and the role of the endocannabinoid system in all of this is important. Human imaging studies do show that that cannabis users have alterations in those areas of brain that contain a lot of CB1, cannabinoid 1 receptors. There are many studies that indicate effects on learning, IQ, motivation, long-term academic careers, and almost all of these studies show that the earlier someone starts, the more frequently they use, and the longer they use, the greater the likelihood of these effects. And preclinical studies, again, support some of the effects that are seen in adolescents. The caveats are that those people who start young and who use frequently may have other risk factors for adverse outcomes. They may come from, they may have been exposed to other traumas. They may come from families where there's some sort of dissociations going on. And there may be a number of reasons for these adverse outcomes that also lead them to be using cannabis. Also, we know that adolescents who use cannabis regularly often use multiple substances. And even though we try to disentangle this statistically, it's not always, we can't always do that. And we don't know yet whether or not these effects persist if cannabis use is stopped. We're concerned because we know that these are vulnerable times when the brain is developing, and so adverse effects may have more permanent types of long-term effects. But we don't really know whether or not when cannabis use is stopped, or whether cannabis use is stopped, that some of these effects might dissipate. We are supporting a very large study right now in adolescents starting at ages 9 and 10 to try and look at what happens over time following exposure to cannabis, as well as many other substances and many other environmental factors, to try and disentangle some of these confounds that affect our overall knowledge. Next slide, please. So just switching over to the cannabis policy side and what the impact is. I'm sure you all know this. Most of the states now have either broad medical marijuana laws, the ones in blue, the green are the ones that have both broad medical marijuana laws and recreational laws, and yellow are those that have medical cannabis laws that include products that are high in CBD and low in THC. But because of the way this has been evolving, because it's still federally illegal, the states vary a lot in terms of how they are enacting their policies. And so those with medical marijuana laws have different allowable conditions and routes of administrations. Some have dispensaries, some allow home growth. And almost all the states have some sort of testing requirements, but there isn't a sort of universal set of standards for that testing. And in many cases, the testing labs may be associated with the growers and not necessarily giving consistent results. So there obviously needs to be independent testing of these products. The states with adult use laws also vary on what types of marketing they allow. Product labeling, they almost all now require product labeling to try and prevent accidental exposures. Some of the states, California allows for delivery. Public consumption, this is a really important issue. It's an important issue because both of the sort of smoke, the secondhand smoke issues, it's also an equity issue that has come up because without public consumption, there is an inherent bias in that cannabis use can only be in, at least smoke cannabis use can only be happen with people who have their own homes. People who are living in apartment buildings may not be able to use it because there may be rules governing that by their landlords. So there's a social equity issue there. Taxation is different, and what taxes are being used for. Licensing is also different in terms of how many, and whether or not somebody can have a license to be a grower all the way to a seller. And expungement and equity, and obviously this is an incredibly important issue because we do know that people, whether or not they're in prison, if they have a criminal record, that can really drastically affect their opportunities in life. Next slide, please. So we're interested in a number of these different effects. We're still learning. I will show you a little bit of data from HIDA, which is the Rocky Mountain High Intensity Drug Trafficking Area report. They've been following legalization in Colorado since it started. This is their 8th volume. They're supported by the Office of National Drug Control Policy, and they use a lot of different sources of data for their reports, including the national surveys as well as state surveys and other information from the states. Next slide, please. This isn't from the HIDA report. This is just a general finding. Again, I think some of these are not terribly surprising, but once again, if you look, this is doing a comparison between states that had passed adult use laws, medical marijuana laws, or no legalization of cannabis. The green are those states that never passed any medical or recreational laws, and what you can see is the green are the ones that are the lowest using groups, which is not that surprising. The red are those with the medical marijuana laws, and the blue are those with the recreational laws. And you can see again, 12 to 17-year-olds don't seem to be showing increases in use, but in those states where you have these more liberal laws, they tend to use more than those states that don't have it. 18 to 25-year-olds again increases, and 26 and up are also increasing. And again, this is such a broad category, and we need a bit more granulation there to really understand that. Next slide, please. So these are some of the data from the HIDA report, and again, I do want to say, so their report is looking at, this is using data from the National Survey on Drug Use and Health, which is this national survey. They define commercialization as starting after 2009. At that point, it was just medical marijuana, but because of some changes in the federal policy, the medical marijuana use started to really pick up in their state, and showing what the use is for those ages 12 and older. And you can see that that use has gone up with commercial use, has gone up with legalization, and has always been above the national average. And again, looking at the 12 to 17-year-olds, we're not seeing that same increase, but at the same time, we are seeing that their use is at higher levels than the national average. Next slide, please. Unintentional exposures, this is also a concern. You can see that in those from 0 to 12-year-olds, you're seeing a large increase in these unintentional exposures. And on the left, you can see that they're usually related to edible products, which even though they're now labeled, they're still very appealing products. Next slide, please. In general, treatment admissions for marijuana have been going down in Colorado, but the group that's showing the greatest increase in treatment admissions is those 26 and older. Next slide, please. If you look at ED and hospitalization rates per 100,000 people, those have not gone up these last 2 years. I think 2020 may be confounded because of all of the because of COVID. So I don't really know quite what to make of that, but I think that this is important also to keep in mind. It's also very important, I'll come back to this in a second, to recognize that presenting data as rates is very important because the population has been growing up, and it has been growing, and therefore just seeing increases in numbers doesn't necessarily mean an increase in rates. Next slide, please. I'm coming back to this teen suicide. Again, I think this is so important. This is a slide I got from Laura Stack, whose son committed suicide. He was using dabs. He was using these very high potency marijuana products, and she started a group called Johnny's Ambassadors, which is mainly meant to teach parents about current products and to make them aware of the risks, especially for their teens. And she gave me these data, which also are from Colorado. If you look at the top slide, you can see that among 15 to 19-year-olds, suicide rates went up in 2015 to 2019. And if you look at the bottom slide, you can see that toxicology showed greater marijuana present at the time of the suicides, while alcohol was not changing. So this is one of those things that keeps coming up in studies, and I think it's important. Next slide, please. And this is just about traffic deaths that are associated with when a driver tests positive. And you've already heard all the caveats about that Dr. Fry presented, that we don't know that even if a driver tests positive, that doesn't mean that marijuana was a source of the accident or was even impairing at the time, because there are a lot of difficulties in measuring in our measurement of marijuana because of the fact that it has a different kind of pharmacokinetics than alcohol and many other substances. Next slide, please. So just the caveats, which I've kind of been saying as we went along. There really were no baseline data collected before legalization went into effect or commercialization. There were the national surveys, but not having baseline data really makes it very difficult to know exactly what the impacts are, and including the fact that oftentimes what is being measured changes following legalization. There's a greater attention to whether or not cannabis may be involved in whatever the measurement is. And so that also has to be thought about, that, you know, when looking at these data. The data on driving accidents or fatalities don't measure impairments. Again, we've already heard about this. And we know that if use is going up in the state, then we would expect that there would be increases in positive toxicology, whether or not cannabis is responsible for the fatality or the accident. Data not expressed as rates can be misleading. And again, a lot of the HIDA data is doing that now, including rate data. And then there were some serious adverse consequences, like the incidence of psychosis, that are just too rare to measure accurately. And also they're using surveillance measures that are available, and they're not all specifically targeted to cannabis harms and may not have sufficient granularity to really assess that. Next slide, please. So I think it's important, as the state is thinking about adult use, to recognize that there is a lot of flexibility in the regulations in terms of how these get implemented, if they get implemented. You know, there are other regulatory schemes besides full commercialization, although most states are doing full commercialization. But the concern around full commercialization is obviously that it's driven by the profit motive. Profits come mainly from heavy users and users who are addicted to the substance. And users who start young are more vulnerable to becoming addicted to the substance. So there's incentive there to appeal to youth and to try to get them to be using cannabis at a time when they're most vulnerable. There are, you know, different types of products can be made available. Serving sizes can be limited. There can be marketing restrictions in terms of where stores or where dispensaries are allowed to be, how many of them there are. Labeling requirements, including health warnings. Most of the states are doing something in this way. Product testing and allowable ingredients. I think, you know, we worry about some of these like vaping cartridges, which may contain these other ingredients that, for example, you know, were likely responsible for E-Valley a few years ago. Smoke-free laws, you know, they shouldn't be any different than they are for tobacco, because there's no indication that cannabis smoke is any safer or any different than tobacco smoke. Consumption sites, you know, whether or not to have them, and if so, where. Licensing requirements, taxes, how much and where does the money go, and again, social equity, which we've talked about. And importantly, I think it needs the deciding bodies. It's very important who they are, and that they have mostly or all public health people that are part of it. That's not what's happening in almost all of the states. In almost all of the states, industry are partners in these policy regulations development. The cannabis industry is treated very differently than the way the tobacco industry is treated. And if federal regulation, if federal legalization happens, you know, I think that that right now we don't necessarily have a big investment of big tobacco and alcohol in our cannabis industry, but that's happened in Colorado. It's happened in Canada. And if this becomes federal, it's more and more going to be the case, I think, within the states. And I think if that happens, then again, you don't want, you know, you need to keep that in mind in terms of who are making the decisions of what the regulations should be. So next slide, please. This is my last slide. So the bottom line to me at this point is that the risks to some are very serious, not to all, but to some. Certainly, you know, women who are pregnant, their infants, and there are some that we just don't know about. Perceptions of harms are universally down, even among individuals who are quite vulnerable, youth, pregnant women. Most, you know, youth don't really think there is a problem driving after using cannabis. Many think that they are actually better drivers. It's also likely that there will be unanticipated harms that we will see with chronic use over many years. And hyperemesis was one that I don't think anybody was really aware of, you know, 10 or 15 years ago. But now people are showing up in the emergency rooms with this cyclical vomiting syndrome and severe abdominal pain that can only be sort of damped down with very hot showers. And it seems to be associated with chronic cannabis use, high potency products, and really can only be stopped by people stopping using cannabis. This suicidal ideation and attempts and completion is something that I think we really need to be paying attention to, and it's not something that we particularly anticipated. The IQ declines are, there's been a lot of arguments about it, but I think to me, the data are pretty clear in people who are using chronically and using over long periods of time that the IQ declines are real. And again, increased vulnerability to infections. Dr. Volkoff just had a paper that showed that people with cannabis use disorder were more vulnerable to breakthrough infections of COVID. And again, even more than with certain other types of substance use disorders, which was a little bit surprising, or maybe not if it's all being smoked, but it's not clear that that's the case. So the data so far don't yet support really major changes in use and in heavy use and cannabis use disorders as a result of passage of the medical or adult use laws. Cannabis use disorders is a bit of this discrepancy in different data sources, but the caveats to that are there are consistent data showing that among the adult populations 26 and older, there are changes in many of these measures. And again, these are not broken down by those who are 55 and older. And I think that's a very important group to be looking at because they may have particular vulnerabilities. We don't know. A lot of the changes that have happened, the increases in use and in the product variety and potency started before enactment of the state law. So the fact that they didn't change when the state laws went into effect doesn't necessarily mean that having legal use it does not have any kind of impact. States with more liberal laws have been and continue to be above the national average on most measures. So regulations matter and they can help mitigate some of the potential harms. I think it's important if adult use legalization goes into effect that there are also strong public health campaigns that are in place when the laws change, and baseline data should be collected now before changes in the laws go into effect. And finally, I think we're in this public health experiment, which is still in its very early stages, especially related to high potency products, mass media campaigns that are pushing for the safety of cannabis, commercialization, and the involvement of big cannabis. And I will end there. Thank you.
All right, thank you very, very much. To go to our third speaker here this morning, Taylor Caskey, the Director of Policy and Government Affairs from the Maryland Medical Cannabis Commission. Committee, we will be taking questions after this. I'd ask you to begin to think about I'm sure you're already thinking about your questions. If you want to be recognized, I will start to keep track of that now. But with that, we'll go to Taylor Caskey, please.
Great, thank you so much, Mr. Chair. I will try to keep my remarks very brief today. A lot of what I had planned on presenting, Dr. Fry and Dr. Weiss already provided a much more comprehensive overview than I ever could. And so what I will do is I'll quickly run through the slides that I have. If there's any additional information I think would be useful, I will provide it. But otherwise, I would like to spend my time mostly focusing on the potential policy considerations for legalization of cannabis in light of all of this data that we have just heard. So with that, we can go to the next slide. Actually, and you can just skip right over this slide. Perfect. So again, both the previous speakers provided a much more comprehensive overview of what youth use looks like these days. While cannabis does remain the second most used substance by individuals under 21, there's not necessarily robust data indicating that youth use is increasing. However, something that I will discuss more in depth later is the significance of the fact that perception of the harms of cannabis is decreasing. And so we can just skip right ahead to the next slide. Regarding driving under the influence, Dr. Fry touched on this already, but the studies generally are not able to establish any sort of causal link between legalization and increased accident rates. What the data do show, though, is that the number of drivers testing positive for cannabis generally increases post-legalization. So it's important to note that could, at least to some extent, be due to significant policy changes and legal changes that are implemented when legalization is put into effect, that would cause an increase in routine testing. So again, it just makes it really challenging to establish any sort of link. For example, if we look at Washington State, they legalized in 2012. And while there's no indication that accident rates increased, the number of people testing positive for cannabis after a fatal crash doubled from 9% to 18%. And then we can just go to the next slide. So looking at cannabis use and cannabis use disorder post-legalization, again, as both the previous speakers have touched on already, the data does reliably indicate that use generally for the adult population is increasing, while use rates among youth is not necessarily increasing. We can just go to the next slide. Perfect. So in some states, there has actually been a decline in rates of cannabis use disorders specifically. So Washington State and Colorado both saw decreases in admissions for cannabis use disorders specifically. And that is the clinical diagnostic criteria for cannabis abuse and dependence. But looking at in Colorado specifically, aside from cannabis use disorder, hospitalization rates and poison control calls were both up post-legalization. So immediately post-legalization, there were increased admissions into the hospital and ER. This could in some part be due to pretty extensive overhauls in Colorado regarding how they build cannabis related admissions. And so, you know, again, with all of this data, it's really important to take everything in context of how it's collected, what was happening at the time. And again, in Colorado, there were increased poison control calls. You can see the numbers there across all age groups. The most significant age group were children 5 and under. And then it pretty much stagnated from 2014 to 2017, and then there was an increase again in 2019. And with that, we can just go to the next slide. So this is what I would really like to focus on for a second. It's just the general limitations of the available research and data here that make it challenging when we're looking at this sort of post-legalization data. And Dr. Weiss mentioned this already, but one of the main constraints here is that there isn't good baseline from prior to legalization. And so oftentimes after cannabis is legalized, we're looking at data that is reported or collected differently than the data was from pre-legalization. And so this is just a policy consideration for folks to keep in mind, that it makes conducting any sort of true comparative analysis very challenging when you're looking at what is basically two different sets of data. Another thing is that all data on cannabis use is relying on self-reported information. So it's study participants, survey respondents, and while cannabis is illegal, adults and youth may not necessarily be totally truthful in their responses. And so that could also contribute to why we see some increase post-legalization. You know, there's a reduced stigma and a more willingness to respond truthfully when cannabis does become legalized. Looking at the number of drug screens performed during traffic accidents and fatalities, pretty much across the board, we do see an increase post-legalization. But again, as I mentioned, this could, at least in some part, be due to the fact that these tests tend to be performed at a much more frequently post-legalization due to changes in the law or other similar changes where they were not previously being performed pre-legalization. And then finally, when we're looking at cannabis use, generally problem cannabis use and cannabis use disorder, there's not really an agreed upon definition for problem cannabis use. So as I mentioned, cannabis use disorder is clinically defined in the DSM-5 as a diagnostic criteria but there isn't really an agreed upon definition for any sort of use that is problematic, but doesn't necessarily qualify as cannabis use disorder. So that just makes discussing problem cannabis use very challenging. And then we can go to the next slide. So this is what I would really like to discuss. Are just some policy considerations for legalization. So there are several distinct and discrete steps that can be taken to minimize the harms that are associated with legalization, because, you know, for all the benefit that there may be, there have to acknowledge that there are some harms associated. And so looking to some of the successful measures that have been adopted in other states, allocating funding specifically for data collection. I think we've heard it a lot over the past hour and a half that there is very much a need for improved, consistent data collection when we're trying to assess the actual effects of legalization. And part of that is it's all relatively recent, and so there isn't good long-term data in addition to lacking any sort of baseline data. But if there is a way to allocate funding specifically for data collection, including that pre-legalization baseline data collection, that would be, you know, extremely helpful. Another big thing that both Dr. Fry and Dr. Weiss really stressed is considering implementing some sort of potency or strength restrictions. And so we heard at length the studies that are linking these high THC, high potency cannabis products to just a plethora of negative health outcomes, including increased youth use, increased hospitalization rates, increased poison control calls. And so something, you know, for lawmakers to consider is what kinds of policy measures can be taken to either limit or de-incentivize these high potency products from coming on the market, to ensure that, you know, we are mitigating whatever health outcomes are pretty well established to be associated with specifically these very high potency, high THC products. The next thing to consider, also Dr. Weiss and Dr. Fry discussed, is just that the general perception of the risk and harm of cannabis use decreases post-legalization as it becomes more socially and societally acceptable. And so the significance of this is it can potentially, you know, present a long-term threat to increased use. And so as we're looking at policy considerations, it's, you know, ensuring that there is a robust system in place prior to legalization, or at least in tandem with legalization, for public outreach and education about the dangers of cannabis, specifically for youth, you know, for the younger population, but really for everyone. Ensuring that there are comprehensive compliance checks on dispensaries. So in particular with youth, making sure that there are ID checks in place, making sure that there are significant penalties for unlawful sales to minors, and other things like that. And then finally, regarding cannabis impaired driving, since as we heard, THC levels, THC blood levels don't necessarily correspond to impairment. One of the most effective things that other states have implemented to address this issue of not being able to really measure impairment is to increase the use of drug recognition experts. So these are folks who are trained in identifying impairment, you know, on the scene regarding a variety of substances, including cannabis. And so opposed to a drug test or a blood test or a saliva test, which again will test for THC levels in the blood, but may not necessarily test for impairment, drug recognition experts are much more effective at actually determining impairment. And so with that, I will conclude. Thank you all for your time today. I'm happy to answer any questions.
Okay, it is 11:30. We've heard from our presenters. If there are members of the committee who would like to ask questions, please use the raise your hand function inside of the Zoom here, and we'll be happy to hear from you. We're going to start with Delegate Robin Grammer.
Thank you, Mr. Chair, and good morning. A question for everyone. So, cannabis use disorder. I wanted it. I think Ms. Weiss had mentioned that we see use disorder expanding even prior to legalization efforts. To me, anecdotally, it feels cultural. It feels like frequently there's a social aspect to it. Sometimes people do it socially. Can be like an isolating aspect to it where people just, it tends to isolate them from everybody around them. I wanted to ask if you could elaborate, like, why do we see more chronic use, more use of potent products? Why do we see expanded use in, for example, women who are expecting? Can someone speak to that, please? Like, why is cannabis use disorder expanding even prior to legalization?
So with cannabis use disorder, I'm not, there's actually some discrepant findings about whether or not it's expanding, but it is, it's a use disorder like any other drug use disorder. So it's really the same sorts of problems that you would see where people have trouble controlling their amount of intake, stopping use, even though they may recognize that it is having, an adverse effect on their lives. So it's, and cannabis is like other drugs. It changes, it is a rewarding effect, and people are using it because it does make them feel better, at least initially. And so it's not that surprising that you see cannabis use disorder. The potency of the products, I mean, this has all really been developing over time based on consumer preferences. Consumers were preferring products that had high THC. And so, as Dr. Fry said, it's much harder to find products that have high CBD. And that's one of the, and so as you have higher potency products, you also have a greater likelihood of becoming addicted. People get exposed to very high levels of THC. They become tolerant to it. They take more. All of these things increase their risk for all of the adverse effects. Also, you could have acute adverse effects, especially in somebody who's a fairly naive user and who really doesn't know what they're getting exposed to. So I'm not sure that it's just the use disorder. It's really just this exposure to these high potency products, and the fact that there are now people that are using them all the time, and we don't know enough about how frequent, how common that is. The data that you saw presented from both Taylor and Patricia show that there's a slight increase among 12 to 17-year-olds in cannabis use disorder, even though there isn't an increase in cannabis use. So that implies that they're using more, or they're using these higher potency products, and that's why that's happening, if that holds up over time.
One final brief question. Data's been mentioned for 2 years now. The gentleman from Brookings came last year and he talked to us about the importance of getting data. I tried to draft a bill about that last year, but it's hard to think about the totality of the data that we're going to need to gather if we're looking to really get accurate information about this. Since data has been mentioned several times today, can one or all of you elaborate about what data we should actually be collecting? I think we're all happy to work on that, but I think we need to understand clearly if we need to start collecting health data. This is the problem I had last year. Everybody wants data, but nobody can tell us what data we need. And it's a big question. Can anybody speak to that?
Yeah, sure. I can at least attempt to speak to this, Delegate Grammer, and we'll start off by saying that I'd be happy to connect with you after this too, because I think that this is a much larger discussion, and it is really important, as all three of us mentioned ad nauseum. And so off the top of my head, it's one of these things where it's certainly if we're looking at impaired driving, for instance, when you look at what baseline data there is now, it's mostly that after a car accident, or if someone gets pulled over for suspected impaired driving, you're immediately just testing for alcohol because it's the easiest, right? You do a breathalyzer, you get the number. If it's above 0.08, that's impaired driving. And so they don't often go the next step to then test for cannabis. And a lot of that is due to existing restrictions in Maryland's impaired driving laws, which to test for cannabis, you would need a blood draw. And if you're pulling someone over and they're blowing a 0.08, and then they might not necessarily be able to pull the blood, right? And so it's very complicated, and it's so much more than just what data do we need. But again, all of that's to say, so in order to establish that data, we would need things like what percentage of impaired drivers are also testing positive for THC. Again, we do have some youth use data because we have the YRBS for Maryland. I'm happy to provide that information. It's actually in the packet that I think was provided to you all this morning. So I don't know if that was helpful at all, but
Yeah,
I'm very happy to connect again after this and discuss in more detail.
I think we're going in the right direction. So maybe if one or all of you could just email what we need to look at to the committee members in respect of all of our time today, that would certainly be helpful. Thank you, Mr. Chair.
Yeah, I was just going to agree in terms of what Taylor said. I think a lot of it has to do with, making sure that the data that's being collected now is not going to be changing once legalization happens, and and that these measures are not going to sort of suddenly become important. But the one other area I think that is important is to get a better sense of the patterns of use, that it's not just whether it's daily or, I think that we need, again, finer granulation on among daily users. How often are they using? And if there's any way to get more information about products, that would also be helpful. But that's been something that the field is struggling with quite a bit and has been for a long time. And I don't know that we're at a point yet where we could say, here, use this thing, and everybody will be able to give you the information that we need. Frequency should be doable.
All right. Delegate Pena-Melnick.
Thank you, Mr. Chairman, and good morning, everyone. Thank you so much for your information. I have a question, actually the first one for Ms. Weiss. Do you think that information about the risk of cannabis use during pregnancy has not gotten to women in the same way said alcohol has? Are the numbers for cannabis use during pregnancy much higher than alcohol use? That's my first one.
Yeah, there's a different perception. I think, the Surgeon General put out an alert, he put out a warning a couple of years ago because of the fact that the rates of use among pregnant women were going up. And even though we don't necessarily have all of the data that we need to say just how harmful it is, there's no reason to think that it's safe at this point. And if you're pregnant, you should obviously want to have the most, you want to have your growing fetus in the most safe environment as possible. But I think there've been a number of studies that show this perception of cannabis as this natural plant, that it's not an unsafe product to use. There was a study in Colorado, which I think has sort of changed their policy a bit, but there was a person who called up all of the dispensaries in Colorado, medical and recreational, said that they were a woman who was pregnant in her first trimester, having a lot of nausea. Is there anything that they have that could help them? And something like 70 or 80% of the dispensaries said, yes, come in, we have cannabis products that might be helpful to you. They can't recommend it. They can say, this is what I've heard from people, or this has been my experience. But 70 to 80% in both medical and recreational cannabis dispensaries were telling women that, that they have cannabis products that might be useful. Now, I think Colorado got alarmed by that and has sort of since then gone into having a greater public health campaigns against that. But that's really frightening. And it's also frightening because they didn't even say to these women, most of them did not say, you need to talk to your provider first, talk to your obstetrician, and then if you want to come in, you can do that. So there is, I think the message about, it took a long time to get people to even believe in fetal alcohol syndrome. That's been, it took many, many years. And I don't think we're not there yet with cannabis. There really is there's this perception that it's natural, that it's a plant. I mean, tobacco is a plant. but it's not, so there is just this, there is this non-fear. And I think some women are using it because they think it will help with nausea, but I think in some cases women are using it because of they think it will help with their anxiety along with being pregnant. And so we don't know yet enough about how long and how much people persist in using it. And we're funding research on that, but we're not there yet.
Thank you. And I have one more question, Mr. Chairman, if I may.
Of course.
For Ms. Caskey. Can you expand a bit on the lack of a clear definition for problem use cannabis or cannabis use disorder? Is it a data issue or more the nature of the substance itself compared to alcohol or harder drugs?
Sure, no, and that's an excellent question. What we've seen when reviewing these, the literature and the data is that, as I mentioned, cannabis use disorder is defined in the DSM-5 as the clinical diagnosis for cannabis abuse and dependence. And there's 11 different criteria, and a diagnosis of cannabis use disorder would be based on, somebody's response to those criteria, range from mild to severe. Given that that is, actually a clinical diagnosis, anything that doesn't quite match or meet the standard for that clinical diagnosis, there's not an agreed upon term within the literature for how to classify that level of use. And so something that we've seen in studies is it will often break it down into a frequent user. So that means, they're using 20 or more days in a month. But whether that level of use qualifies as problematic or something that is still not a healthy level of use, but might not reach quite the level of cannabis use disorder, is where there's kind of a breakdown, and it makes it challenging to assess any sort of pattern of use leading up to cannabis use disorder that, again, is still problematic, but is not going to be clinically recognized as a use disorder.
Can I interject that it's not the amount of use or the frequency of use of cannabis, because you can have patients who use quite a bit of cannabis and THC to treat their symptoms. You could have someone with Parkinson's or Tourette's or so who need THC or using it frequently, but that's not use disorder. Use disorder, it could be a little bit or a lot, but if the continued use of the substance is negatively impacting either their personal life, their job, if they're spending a lot of time, drug seeking, it's those behaviors and the negative impact on their quality of or on their lives that is what drives towards a diagnosis of use disorder. It's not frequency of use, it's not what you're using, because there are many clinical conditions that require more frequent use and may require THC dominant medications. So it's negative impact and continued use despite the fact that it's negatively impacting your life. That is what guides you towards a diagnosis of cannabis use or any type of substance use disorder.
Yeah, thank you so much for that clarification. Yeah, what I was trying to articulate here is that other than cannabis use disorder, there aren't a lot of measures for problematic use. And so as Dr. Fry just pointed out, frequent use in and of itself is not indicative of problematic use, right? And so that is something that makes it really challenging when discussing any sort of distinction between general use, medicinal use, problematic use. Like there's no real solid, consistent definition for problematic use. That may be use leading up to abuse and dependence, but not quite there yet. And I don't, if either Dr. Weiss or Dr. Fry would like to add to that, of course.
And I would just like to throw in that, when Dr. Weiss went into hyperemesis syndrome, in my opinion, that's a symptom of use disorder. Those patients it's very difficult to convince them that it's THC that's causing their symptoms. They're hell-bent on continuing to use THC despite the fact that they are suffering, physical problems, hospitalizations, dehydration. So certainly any diagnosis of hyperemesis, cannabis hyperemesis that continues is, in my opinion, is almost by definition use disorder as well, because they are continuing to use cannabis despite the fact that they're suffering negative physical effects from the plant.
So can I just also interject one other thing? I think that adds to sort of the difficulty when we talk about this, is that we talk about cannabis as an entity, and we're really talking about so many different things. We're talking about plants that are high in THC. We're talking about extracts. We're talking about, mostly CBD or all CBD. It makes it really difficult because these things are all getting put together into one category, and they're really not one category, and the risks associated with them are really very different. And I usually try to emphasize that in the talks that I give, that we need to be clear in what we're talking about in order not to add to the confusion. But it's very hard because it is a plant. It's in many formulations. There are many routes of administration, and there are many components with differing effects and differing risks associated with them.
Thank you, Mr. Chairman. I appreciate the conversation.
Thank you very much. Delegate Lutke.
Thank you, Mr. Chairman. Dr. Weiss, Dr. Fry, Ms. Caskey had offered at the end of her presentation some suggestions for how we might, what types of public health interventions we might look at spending some of the, frankly, the revenue that we would get from recreational cannabis sales on. I wondered if you had any thoughts to add to that in terms of, how to deal with the negative externalities.
Yeah, I think the pregnancy issue is important. Within the cannabis community, there is a lot of misinformation, and they base a lot of their comfort with using cannabis in pregnancy based on some old studies. There's one from Jamaica where they followed children from this group of women that lived in an area, but they don't factor in other things that impact pregnancy and fetal outcome, like food, water, sleep, stress, anxiety. And so there have been issues. The issue with the dispensaries is real. It happens here in Maryland. A pharmacist at a dispensary was reprimanded and eventually fired for not selling cannabis to a visibly pregnant woman. So the dispensaries need to be educated on the impact of cannabis, or the potential impact of cannabis on the fetus. We need to do the same type of public service announcements that we did for alcohol and for tobacco and cannabis. I'm not saying that cannabis is never indicated, but anything in pregnancy, the benefit has to clearly outweigh the risk to the mother and to the fetus and to the development of that child. So if you have a patient with hyperemesis due to pregnancy, and and pharmaceuticals have not worked, and it's about, do we take this mother away, admit her for IV fluids when she has younger children at home, and cannabis just a little bit can help with that hyperemesis. That may be indicated, but as the speaker said, the physician or the provider needs to be involved. That we need to kind of break this myth that cannabis is fine, that babies are fine. As Dr. Weiss, pointed out, the endocannabinoid system is intricately involved in fertility and in pregnancy and in suckling. We don't know enough about that to manipulate it. But if the benefit of using cannabis outweighs any risk of using cannabis, then it might be appropriate. But the cannabis community itself has this idea that the plant can do no wrong, and that and like you said, it's a plant, it's natural, and it's better than taking a pharmaceutical. So I think some education on pregnancy would be very helpful. I think too, focusing on adolescents. My feeling is that any kid who occasionally experiments with cannabis, adolescent, I'm not that concerned about. It's the continued use. It's the use of the continued repetitive use of cannabis that to me is a red flag. So I don't know what's the chicken and the egg when it comes to mental health issues with these kids as they develop. And much as Dr. Weiss indicated that it's hard to tease out what came first. Is there a dysfunctional family? Is this kid self-medicating because he has an undiagnosed mental health condition like depression or bipolar disorder or early onset psychosis, that they're using cannabis to feel better? So any persistent use of cannabis in an adolescent, I think that we need to take a harder look at what is causing that child, that adolescent, to use cannabis in the first place. So perhaps parental education on, if your kid is, every now and then with their friends, experimenting with a little marijuana, that's not such a big deal. But if they're using it over and over again, there's almost always some underlying diagnosis that has not been made and that they are not receiving adequate medical attention for.
So I would agree with everything that you said. And I think that I'm glad you mentioned parental education, because I think that really is a very important part of this. And I think that's one of the other perceptions that we seem to be struggling. And that's why we have this slide that Jonathan Calkins had with the cappuccinos and the Coca-Cola. I mean, just getting across the idea that this is not the same product that people were using 20 years ago, and that those products had a better ratio of THC to CBD, and if CBD is helping to counter some of the negative effects, that might be why we didn't see as much of an effect on psychotic disorders in the past. So getting parents to also understand that this is not a harmless. I think a lot of parents would say that they would rather that their child use cannabis than alcohol, and cannabis can really affect learning and motivation, and it is not the same product, and getting that message through is important. I think the other message is the one about, I think that we do know that it's a risk factor for psychosis. If somebody has a family history of psychosis, then they should be warned not to use cannabis at all, that in fact they could have a bad response and that they could in fact go on to having a disorder. And the one other thing I was going to say about just in terms of policies is that there's also a study that was done by Rosalie Krapula and her colleagues looking at how much, what a person could purchase in all of the states that have adult use cannabis. And she was using what she was considering a standard dose of 10 milligrams. And in all of these states, people could purchase thousands of doses at one time. I mean, the amount that they were allowed to purchase was much more than anyone was going to even use in a month. So there's just been no restrictions on a lot of these things that could be restricted and that could be limited.
But at the same time, I don't believe that people should go to jail for cannabis, even if they're.
I agree with you. I'm completely not in favor of that.
Are there other questions from the committee? I have several if the committee is finished. So some of my questions, I'm going back to Dr. Weiss, and one of the things I think you said this, one of the notes that I took at least, the cannabis industry is being treated differently than the tobacco industry. Can you expound a little bit more on that? Because I think one of the discussions that I certainly, and I've been hearing a lot from people on every side of this, it has been that, we need to regulate this in some way. And then you inevitably start talking about, well, here's how we regulate the alcohol industry. And then relating this then to tobacco, when we didn't make it clear from the beginning what the health effects were of smoking, of excessive smoking or even baseline smoking, people engaged in it, and we had major health effects that have happened down the line. Can you talk about how you perceive that the cannabis industry is being treated differently than that of the tobacco industry?
So again, it gets very complicated very easily, because there are these sort of there are groups that are focusing on developing medical products. There are groups that are, and with the tobacco industry, there's no medical benefit for smoking cigarettes. And cannabis falls into this very odd category where it's not it has very clear risks for certain people, but it also has certain medical benefits. At least certain types of products would have those sorts of benefits. And the industry can be kind of all over the place. And some places, these are sort of smaller, they're smaller, they represent smaller interests, but the fact is that they are part of all of the discussions of how these regulations are going to get implemented. And even for our researchers, it's very hard for them not to somehow be involved with the cannabis industry in one way or another, either as giving talks, being on panels that they are subsidizing. The cannabis industry has a very strong hold, and they are going to have a much stronger hold if it becomes federal. But then they have power to lobby, and the industry has, they've fought that, like in Colorado, I think they initially did not, I don't think anybody expected the edible market to take off quite so much when it did. And then the state tried to sort of take that back, keep edibles from being on the market. And they couldn't do it. I mean, there was a lot of backlash for it. And some of that does come from industry, where there is a lot of money, and a lot of the industries were backed by people who were very, very wealthy. So you have a mixture of things. It's not that everyone who's in the cannabis industry is bad, but you've got a mix out there. And again, if it becomes legalized federally, then, what we've seen in Canada is, the tobacco industry owns, at least half of the larger cannabis industries there. The alcohol industry is also really involved. And, we have an inherent distrust of the tobacco industry, because we recognize that they are getting money based on people's, risks to their health. And that mistrust is not there for the cannabis industry. And so they have been players, in almost all of the states that are making, determining regulations. And so, that was sort of the point. And again, it's not so simple as it is with the tobacco industry, but it's risky. Because in fact, if you're talking about commercializing something, then they have very clear interests, and their interests are not about, at least some of them, the interests are not about the health of the consumer. And again, yeah.
Right. And I mean, again, what all of you have talked about today is that there's a higher risk of or higher propensity for addiction, I guess. And it's I've seen the research regarding the ability to come down off of addiction for marijuana. So I understand that, but the higher risk of that for kids, and we did see the track record of kids and what the tobacco industry did there. So I wanted to kind of get to that, but it leads me to another question quickly, and I know we're going to run out of time here a little bit, but sort of a broader question on dosing. I at risk of potentially alienating some part of the people in my district, I have not used marijuana. And Delegate Moon is not surprised and is laughing at me. That took about 5 seconds. All right, that's fine. But I guess there is a question in my mind as for dosing, and I'm going to probably make a unhelpful comparison in some ways, but when you buy alcohol, you can see the percentage of alcohol, whether it's the beer that you drink, the wine that you drink, the scotch, the bourbon, whatever. You can see the percentage. First, I genuinely would like to know, is there a similar measurement that is used across the industries across the country? And then second, do you have more information as to how those are used to limit availability to younger people or people under 18?
So, so of course, all the adult laws don't allow selling to those people who are under 18. This has also been something that's been a big, it's been a difficult issue for the research, for researchers to know. There are, so actually what NIDA just put out a notice asking our researchers to report their results using what we're calling a standard THC unit of 5 milligrams. And we base this on a number of different research studies that seem to indicate that 5 milligrams was not, it has varying effects depending upon your experience with cannabis, but it's not necessarily a dose that would have, or an amount that would have no effect, but it shouldn't have the sorts of harmful effects that we are worried about. And we're very interested in studying what the different time courses are, what the different interactions are between THC and other components of the cannabis plant. But this is something that we're asking our researchers to do, because we have the sort of control over our research community. We're funding them. But I would really, and I've been talking to the Cannabis Regulators Association about this idea also, because I think we would be really happy if this sort of thing became commonplace in all of the products that are being sold in all of the states. And right now, most states do show the amount of THC on their edible products, and they have some different what they're calling serving sizes. So some of them are using 5 milligrams and some of them are using 10 milligrams. And part of the reason for the 5 milligram serving size was because packages allow 10 servings per package. And the thinking was that 50 milligrams was unlikely to cause somebody who accidentally ingests it to go into a coma, or to have the very, very serious side effects that could happen if somebody were to, if a young child were to take in 100 milligrams. Again, these are all just sort of ways of trying to think about mitigating harms. I would really love it if we could, but we'd have to also train consumers. So, if you ask people what they're taking, they're absolutely the worst reporters on what they think they're taking, and they don't know what the potency is. They don't know, and there are people working on using pictures of products to try and get a better sense of things. But I would very much like to see a standard unit be part of anything that's sold, so that even if somebody is buying a concentrate and it's got 100 units in it, at least they know that, at least they know that I'm buying something that's actually 100 units of this. And and we're not saying this is a recommended dose. We're not saying, because we don't know. It depends. There's a lot of different reasons to use these things for different causes, and it's complicated because, again, the plants can be different. They can have different amounts of CBD. But we wanted to start somewhere, and so we started with this idea of a 5 milligram unit of THC, which, again, we're asking our researchers to use, and we really like it to also be incorporated into the products that people can buy from dispensaries. And then we need to teach consumers to understand what that means.
But needless to say, if people were growing their own, and I'm not going to go too much longer. If people were growing their own, it would be virtually impossible to determine the potency or the amount that people were using at a period of time. There would be literal or virtually no ability to regulate that.
Unless they wanted to send to some sort of analytical lab to find out. Yes, that's right. Yeah.
Which would seem to run counter to the reason
right.
we want to do
Right.
that. My very last question, promise, is going to the point that was made by Taylor Koski about needing a blood draw to test for cannabis. Are you aware of anywhere across the country that has a similar system to that of the breathalyzer system for marijuana? And I don't believe that there is one anywhere. I don't believe that exists. Are there any that people are in production?
Sure.
Go ahead.
There are measures using saliva, which seem to be a better indicator of recent use. And there are people that are working on it, also working on ways of trying to combine some sort of app that would allow you to measure some kind of impairment along with a test of THC. But it's still very difficult, but I think there's some hope that the saliva measures will be a better indicator of recent use than the blood measures are. Taylor, did you want to say anything else?
No, that was exactly what I was going to say, is that, for a long time, historically, the blood draw was the only way, but now the most recent innovations, as it were, in the area are looking for a saliva test, which can be done more quickly and is less invasive than a blood draw.
I guess I'm not going to go into the constitutional arguments as to whether it's a search or not, because it's 12:04, and we could turn this into a committee hearing for the Judiciary Committee, but I think everybody would go crazy. So we'll stop there. I want to thank everyone for being here today. Thank you all very much for your time and for a really interesting session today. We will be back again with our next hearing as I go over here to my notes. On Wednesday, October the 27th at 10 o'clock regarding issues related to criminal justice impacts. All of our future hearing dates are posted to our work group page on the Maryland General Assembly's website. And the materials from today's meeting will also be posted on that work group page later today. Thank you all very much for your time. Thank you very much for your attention. And we will see you again on October the 27th.